Okay, hello everyone. We're just going to wait a few more minutes as people are getting admitted to the chat, to the webinar. Just give it one more minute. Okay. Welcome everyone to our Canadian Guidelines for Post-COVID Condition webinar series. We're super excited to have everyone here today. My name is Heather Travis. I'm the Science Manager for Cochrane Canada and the CAN-PCC project, and I'm excited to be your host and facilitator today. Joining me are three exceptional collaborators to this project. We have Dr. Ignacio Neumann, Dr. Robbie Newlewat, and Kimberly Flowers. Unfortunately, Melissa Croskery was unable to join today due to illness. Together, Robbie, Ignacio, and Kimberly will be walking you through the recommendations related to neurological and psychiatric topics from the Canadian Guidelines for Post-COVID-19 Condition. Here's some information about your speakers today. Dr. Robbie Newlewat is the CAN-PCC project co-investigator. He is also a Guideline Development Group member and an associate professor for the Department of Health Research Methods, Evidence, and Impact at McMaster University. Dr. Ignacio Neumann is co-chair of the Neurological and Psychiatric Topics for the Guideline team, along with Melissa Croskery. He is a professor at the San Sebastian University in Chile. He is an assistant professor in the Department of HEI at McMaster University, and he is director of the Grade Connoisseur. We also have Kimberly Flowers joining us today. She is our CAN-PCC patient representative who serves on the Guideline Development Group as well as on a guideline team. As we begin today, it's important to acknowledge that the work of CAN-PCC takes place across Canada, a land that is the traditional, ancestral, and unceded territory of many Indigenous nations. From coast to coast, these lands are home to the First Nations, Inuit, and Métis peoples who have stewarded them for millennia. We honor their rich cultures, their languages, traditions, and histories. For our McMaster University presenters, we recognize that McMaster sits on the traditional territories of the Mississauga and Haudenosaunee nations within the lands protected by the Dish with One Spoon Wampum Agreement. Here are a few quick housekeeping items for today's webinar. Please submit your questions using the Q&A feature. While we're trying to keep an eye on the chat, the Q&A is your best way to reach us. Wherever possible, slides are presented in English and French. For more complex slides, we're going to present the English first, followed by the French. A recording of the webinar and slides will be available on canpcc.ca a few weeks after today. So now I'm going to pass it over to Robbie.
Thank you, Heather, for the introduction. Welcome, everyone. So I will start the presentation for the content that you're most interested in here. So about the Canadian Guidelines for Post-COVID-19 Condition, CAN-PCC, today specifically about neurological and psychiatric topics. And I have Ignacio and Kimberly as my co-presenters here. Next slide, please. Just some disclosures, as was perhaps already mentioned. So I'm the director of the Michael G. DeGroote Cochrane Canada Centre at McMaster University and co-director of the InGuide program. And there are no conflicts to declare for Ignacio and Kimberly. Here you can see the objectives for our presentation, our webinar. We will share evidence-based PCC or long COVID recommendations related to neurological and psychiatric topics. We will share how the CAN-PCC guidelines can be incorporated into practice and highlight some of the tools. And we want to increase awareness of our guidelines and our tools. So as all of you, most of you know, post-COVID-19 condition or long COVID is a relatively new and complex condition affecting different parts of the body. And here you can see the definition we have used throughout our project since early 2023. We have applied the WHO definition, which in a simplified version you can see here, PCC or long COVID usually appears within 3 months from the acute COVID-19 infection, unless at least 2 months. Symptoms can vary and change or worsen over time and significantly impact daily life. We know that around the world, about 400 million are estimated to have had PCC or long COVID globally. This is probably a somewhat outdated estimate by now, and the number could be higher. In terms of the impact on people in Canada, we know that about 1 in 9 adults, or 3.5 million adults, have experienced long-term symptoms after COVID-19 infection. And I believe this information is from 2023. So this could be a higher number by now as well. And at that time, 600,000 adults in Canada with long-term symptoms missed days of work or school. So there's a very large impact if you look at the whole population. We also know that there are over 200 symptoms and conditions associated with long COVID. Here we show some of the most common ones. So fatigue, pain, shortness of breath, brain fog, sleep problems, post-exertional malaise. But these are examples of some of the most common ones. The number indicates there are many more. So for now, before I continue tell you more about the overall project and our methods, I first want to give it over to our patient representative, Kimberly, to share her experience.
Thank you very much, Robbie. I'm Kimberly Flowers, and I am a patient representative on the CAN-PCC project. Before I give you a little bit of my background and what my participation was like in CAN-PCC, I'd like to acknowledge that March 15th was Long COVID Awareness Day, and last week, throughout the week, there were a number of awareness activities, and I want to acknowledge the patient community for leading the charge in those activities. So I just wanted to acknowledge that. So a bit about my background. I have a cancer patient, actually, advocacy background, which and then in 2021 I've contracted COVID, and it took about a year for me to get diagnosed and also referred to the long COVID clinic here in Edmonton. Since then that clinic has closed. This added a whole entirely new layer to my already complex health profile. So I'm learning along with all of you as to how to navigate this very new and complex health condition. Some of my most prominent symptoms are POTS, which is post-orthostatic tachycardia syndrome, and PEM, which is post-exertional malaise. Also, fatigue plays a prominent role, and that was a bit of a carryover from my earlier cancer diagnosis, and also brain fog. So it's made for a really complex situation going forward. So when you face something like that in your life, it can be very daunting. It can be very frustrating. You can be left really lost and not feeling very vulnerable. And so one of the ways I took that experience and tried to make something out of it, so to speak, was empowering myself. And empowering myself happened in a number of ways. It was educating myself about my health condition. It was really treating my interaction with the health system as a team effort. And then eventually, once I was well enough and strong enough, I took on a role of advocacy and got involved in a number of research projects. And that led me to getting involved in CAN-PCC. I certainly acknowledge that we were facing something very new and unprecedented with the COVID pandemic. And the CAN-PCC project was a way to get involved and have a positive impact on what was happening. I want to acknowledge a number of other patients who are involved in this project, and we are involved throughout different committees and layers throughout the project. So I myself am part of the guideline development group, and I also sit on the guideline team for neurological and psychiatric topics. And so a number of my other patient colleagues work on the GDG as well, and other guideline development teams. What I have to say, and I know that that takes a tremendous effort when a person already has a compromised health baseline. And so that does absolutely take a tremendous effort to be involved. And I think, though, it is also very important. So patients who have the ability and are able to, I do strongly encourage that you continue with advocacy. Do what you can from where you are. I think that's such a key message. And simple things like sharing information, sharing posts, sharing your experience helps to unify our patient with lived experience voice and helps inform researchers and the health community at large. So what was it like being part of the project? Sometimes walking into a project like this, you may feel perhaps intimidated or daunted, but the way this project was set up really made me, and certainly I think I can speak for the other patients, very comfortable in participating. It was very clear from the outset that our voices were equitable with all the other voices at the table. And the way the project was also set up, it meant that it was a very meaningful experience for what we were bringing to the project as patients. It wasn't just token participation. So I really appreciated how the project was handled in that respect. And there was plenty of opportunity and always an opportunity for our voice to be heard. And not only from our own personal experiences with long COVID, but also many of us were able to bring the voice forward from the long patient community as well, long COVID patient community. Sorry, as you can see, I sometimes stumble over my words. Thanks, brain fog. So I guess the message to the community at large, and more specifically to those living with long COVID or post-COVID condition, as we call it in this project, is that there is so much that is out of our control in this new disease, and we're all keeping in mind that we're all navigating this unknown together. So I think it's really important to speak up, but also have a willingness to listen and learn from each other and educate ourselves. So in closing, I again want to thank the project for allowing having patients involved in the entire process from start to finish. And in closing, I want to acknowledge and thank the long COVID patient community for continually advocating. And by doing that, we are uniting, and really that is the way that we can have a strong and impactful voice and have a positive impact on this unknown going forward. So thank you so very much for joining us today. We're really glad that you're able to be here with us. Thank you.
Great, thank you, Kimberly, for that. And I just want to add, Kimberly has been an incredible collaborator in this project on the GDG as well as this specific guideline team. So thank you very much. To continue then with some of the background and as well as our methods, also from, I believe this was 2023 as well, we know that 1 in 8 adults in Canada who sought support for their symptoms felt they received appropriate care. So the majority felt they were not receiving appropriate care. And this, of course, has been an important issue that we're trying to address now with these guidelines. Next slide. So that's why we're working together on CAN-PCC to improve care. So who are we? We are over 150 collaborators across Canada as well as internationally. We combine representatives from health professionals, persons with lived PCC experience and their caregivers, policymakers, health economists, researchers, and together they bring to the table expertise in, first of all, of course, the lived experience of PCC and related care, as well as taking care of people with PCC or long COVID, expertise in guideline development, evidence synthesis, knowledge mobilization, as well as impact evaluation. We have 6 specific guideline teams. Each guideline team is focused on a specific topic and includes a diverse range of experts. Again, you see here, we aim to bring together persons with lived experience, health professionals, physicians, economists, researchers, as well as, for example, nurses. And as Kimberly already addressed, we have several persons with lived experience involved in our project. I want to make it very clear that the people you see here on the slide are the people who were involved in the guideline teams and the guideline development group. They underwent training for that process, and they were equal collaborator on developing the recommendations. So really big thanks to all of you, in addition to Kimberly, of course. So some of our overarching project principles and processes were to aim for balanced representation, to work with key groups and collaborators, to have a transparent and evidence-based systematic approach. We had independent management of conflicts of interest. Everybody in the project declared their interests. An independent party assessed them for potential conflicts, which was then managed. And as I indicated already, we used standardized training for all our collaborators, so everybody had the same understanding of the process that we would go through. We also had a very important focus on equity or equity seeking groups. You can see here the groups that were considered specifically in our project after a selection prioritization process. And these included indigenous peoples, refugees and migrants, TUS LGBTQIA+, older adults, women and pregnant women, racialized groups, people experiencing homelessness, and justice-involved people. And that was just a short summary. We have equity experts who could tell you a lot more about their framework and their approach, which affected every step in the process in our project. So we have developed around 100 recommendations for 6 prioritized topics. And the 6 topics include prevention, testing, identification and diagnosis, pharmacological, non-pharmacological clinical interventions for PCC, neurological psychiatric topics that we're talking about today, pediatrics and adolescent topics, as well as healthcare services and systems and social support. Here you see a statement from Dr. Mona Niemer, the Chief Science Advisor in Canada. While scientific studies are undertaken and the evidence base grows to fill knowledge gaps and inform practice, individuals living with PCC require care, support, and treatment now. This was true just before they decided, or before it was decided that CAN-PCC should develop guidelines. This was reiterated last year with an updated report. Here you can get an idea of what's involved in terms of developing a CAN-PCC recommendation. You can see on the left, we get input from the public as well as government representatives, patient representatives and their caregivers and health organizations. This was primarily to select topics and questions, as well as many of you probably know by now, is comments on draft recommendations, which we take in account before we finalize them. You can also see every step of the way that we go through from 1 to 8. And you can see on the right all the different groups that are involved in our project and at which step they provide input. So if there's no arrow, all the groups, where the arrows are, all the groups are involved. Otherwise, the specific group is indicated. For example, the guideline teams developed the draft recommendations, and the guideline development group at step number 7 approved recommendations. This is the full process we went through for every recommendation. So with our recommendations, we indicate strength and the direction of the recommendation. So what does that mean? The strength can either be strong or conditional, which is sometimes also called weak. And the direction can be for or against a treatment or an option. So for example, the guideline group recommends, which would be strong if we use the word recommend, recommends drug A to treat the common cold. And so this is a strong recommendation for the intervention. Here you can see all 4 options that we have when creating a recommendation. So it can be a strong recommendation for an option, it can be strong recommendation against an option. It can also be a conditional recommendation for or a conditional recommendation against an option. So related to this, and also important to know when we issue conditional recommendations, especially, is what does certainty of the evidence indicate, or also labeled as quality of the evidence. So the certainty of the evidence is about how confident we are that the true effect of the intervention falls within a specific range. So we are very transparent and objective about what the evidence tells us. We're not trying to make it look stronger than it is from the scientific evidence. So what does that mean in terms of implications for practice? For patients, strong recommendations, people will want to follow it and a small proportion would not, while a conditional recommendation, with a conditional recommendation, most people will want to follow it, but many would not. Most people will want to discuss it with a health professional first. So that's the main or one of the important differences between having a strong recommendation or a conditional recommendation, which may also depend on the certainty of the evidence. You can see here also what it means for healthcare professionals and policymakers. I won't go into detail here, but the slides will be available afterwards. So what does it mean, a conditional recommendation for somebody who is seeking care? Most people would want to follow it, many would not. So your healthcare professional should understand that different options will be appropriate for different people and should support you in making decisions that align with your values and preferences. Okay, so having given you this background about the overall project and some explainers about our methods, I now want to give it over to Ignacio to talk about some specific good practice statements and recommendations.
Thank you very much and welcome everyone. Good afternoon. So we have more recommendations in our guideline. We select those we believe were more relevant for you, but I invite you, and we will talk at the end. I invite you to visit the website and take a look of all the recommendations. So when we start this journey, we first developed good practice statement, and the reason for this is we believe at that time that they were messages that need to be conveyed very quickly, and they were important for the care that people with PCC were receiving. And one of the first good practice statement we put out was from our group was what health professionals should inquire about limitation in daily activity and quality of life on an ongoing basis in people with diagnosed suspected post-COVID condition. The rationale for this is because we believe that having post-COVID condition may put people with a label, and they may not get asked specifically about daily activity and quality of life. And then if this alteration of this dysfunction are not perceived or diagnosed and treated, they may go unnoticed and people may not get appropriate treatment. We made the remark that inquiry should be accessible, appropriate, and culturally responsive, because we don't want to, it's important for health professionals to inquire, be mindful about how people will perceive this, because if the label of post-COVID condition may not be well received for some patients, so it has to be a dialogue with the people, and in a way that people do not feel uncomfortable. Next, please. And then now we move to the recommendation that were the good practice statement were based on indirect evidence. We did not conduct a systematic review and evidence synthesis. and they were put very early in the guideline journey. Then now we move to evidence-based recommendation, and this is the only strong recommendation of the guideline, and is about screening for depression in people with post-COVID conditions. So the recommendation is in people with PCC, the collaborative CAN-PCC recommends depression screening over no screening. The important remark here is the screening is intended to ensure that in addition to post-COVID condition, symptoms of depression can be detected and treated. So because sometimes, and post-COVID condition is associated with a lot of symptoms that may mimic depression. But if people, in addition to PCC, have depression, those symptoms, the depression needs to be treated and follow up accordingly. Otherwise, the depression may not improve. So it's not enough to say, well, if you have, for example, problem with with sleeping, eating, just attribute this to post-COVID condition. Clinicians need to ask whether this in reality represent another disorder, which is depression, and to be treated accordingly. The certainty of the evidence was coming not from COVID condition. Actually, we found more evidence in the general population. So there is not a lot of evidence in post-COVID condition patients, more on the general population. So we found a very large systematic review showing that doing a screening in people in the general population at 6 months improved mental health outcomes. So the basic assumption was that if this works in the general population, which has a relatively low prevalence of depression, in a population that may be at more risk of depression, like the PCC population, the effect will be equal or even higher. So the desirable effect was considered variable, and depending on the population, if you are at high risk of depression, probably the benefit of screening will be higher. But if you are at the low risk end of depression, the benefit might be equal to the general population. The undesirable effect of the screening is mainly be labeled as positive, but without depression. So the false positive were considered trivial. And also the false negative, given the sensitivity of the screening, was considered also trivial. We believe that in general, putting the balance, the benefit and harms of screening, there was a lot more benefit than harms from doing the screening. And the intervention was considered acceptable and feasible. One important thing, and I think one important message we want to convey is that we're not saying that people with PCC, all the PCC symptoms have a psychiatric origin. We are saying that depression is a frequent condition in people with PCC that needs a specific treatment and follow-up. So if people are presenting with symptoms that may suggest depression, screening might help to identify individuals that might benefit for pharmacological and non-pharmacological treatment. The second one. So the second recommendation is closely related to depression and is about anxiety screening. So the CAN-PCC collaborative suggests the use of screening for anxiety over no screening. This is very similar to depression, but what we notice, please, this following slide, please, the next slide. So the evidence base for anxiety screening was smaller than from depression, and this is something that is very frequent. So you have more studies assessing depression screening than anxiety screening. So in this case, the uncertainty was higher. That's what means certainty of the evidence is very low. We know less about anxiety than we knew about depression. But in general, this also is coming from the general population. Doing screening in the general population is associated with a moderate benefit. And this, if you screen people and people get identified properly and treated, the mental health outcome at 6 months improve. And the rationale was the same. If this works in the general population, in a population with a higher risk of anxiety symptoms, this might work even if equal or even better. So the desired effect were considered moderate. The certainty of evidence, as I said before, is the evidence base is not as large as depression, but we believe overall the benefit is on the side of doing screening. The intervention one was acceptable, considered acceptable for most people, but again, and it says varies because there is this issue of labeling people with PCC symptoms. Okay, this is you have this symptom because you have anxiety, and this is what some people may not feel comfortable with. That this is what we want to avoid. One issue is having a PCC and all the symptoms that PCC have are associated with, and another is of anxiety. So label some anxiety will not be acceptable. So for some people, for fear or beer, everything will be attributed to anxiety. And we try to make clear in the recommendation that that is not our intention. The following, next recommendation, please. Now we are going to, this is about screening people with PCC, in general people with PCCs. Now we are going to a specific population. So in this is people with PCC and PEM, post-exertional malaise. The CAN-PCC collaborative suggests cognitive behavioral therapy in addition to pacing. Why in addition to pacing? There is another guideline group that made a recommendation in favor of pacing. So we are building on what was done by another guideline group. And so, well, in addition to pacing, we are suggesting cognitive behavioral therapy. And this is, the next one, please. This actually is based on direct evidence suggesting that cognitive behavioral therapy in people with post-COVID condition and PEM may provide a small benefit in terms of improving symptoms. The harms of the therapy were considered trivial. The certainty of evidence was very low, and this is because the evidence is new. Their studies are small, but so we may find some studies in the future that may give us more evidence to consider. There were some issues about resources. Providing cognitive behavioral therapy was not considered easy in terms of resources. So that may have an impact in equity. People that are not equity-seeking population may not be access this intervention equally that other population. But we thought that in general, even considering the resources, providing cognitive behavioral therapy to people with post-COVID condition and PEM was probably feasible, although we acknowledge that this may be variable across Canada. The next one, please. This is a recommendation that is maybe now is less relevant, but at the time we were developing the guideline, there was big news about using hyperbaric oxygen therapy. So people get into a chamber and they receive hyperbaric oxygen, so higher than usual barometric pressure of oxygen. And this was on the news, and a lot of people were asking questions about whether this can help, and specifically in people with cognitive impairment. So there was the next one, please. There is a randomized trial that was conducted in Israel that was a small randomized trial. So it's a small study, not a big study, that showed that there may be a small benefit in using hyperbaric oxygen in people with post-COVID condition and cognitive symptoms. However, the number of people studies is very small. This is a very preliminary result. There are around 13 facilities of hyperbaric oxygen across Canada. So well, this is a kind of a therapy that is really experimental at this point. It's not possible to implement it, and we don't know a lot of whether this actually provide a benefit or not. So at the end, we decided, well, given the issues with the feasibility of the option, we think, well, there are 13 facilities across Canada, it's not possible to provide intervention to all. Consider that the evidence was initial, only one study, it was very few patients. Still, we don't know much about the intervention. we made a recommendation against. So, well, in general, this is not part of the standard management of people with post-COVID condition, but in some cases, if you have access and if you have, I don't know, may be an option. So we're not ruling it out, but given that we don't know much about how this intervention may work, we decided to make a recommendation against. But it's a conditional recommendation. So, well, it doesn't say should not never be used. So in general, should not be part of the routine care, but in selected cases, this might be an option. So that is going back to what Robbie was saying about this, what is the meaning of conditional versus a strong recommendation. So in summary, not much evidence. We don't know much about whether this provides a benefit or not. Some initials suggest that may be the case, but a lot of issues about how to implement if this effect actually exists. The next one, please. So another question that we receive is, well, people with post-COVID condition and brain fog, with or without post-exertion malaise, whether they should take a CNS stimulant. For example, CNS stimulant are used for a variety of conditions. If you have brain fog, maybe this might help you. So we received that question and we look for the evidence and make a recommendation about it. Please, the next one. So what we found evidence, not much evidence, but initial evidence. And in this case was not directly from people with post-COVID condition, was from a related population, but we think that the effect of observing the studies was reasonable considering the post-COVID condition. The benefit in terms of improving cognitive symptoms was small. So people taking CNS stimulator get a little bit better. But there was a lot of adverse events. And we thought that people may value this adverse event differently. Some people may say, well, I'm willing to risk the adverse event because we get a small improvement in cognitive symptoms, but other people say, well, no, the adverse event is too much for me. I'm not willing to take the medication. Also, there was some cost associated, and in general, CNS stimulants are available and is feasible to implement. But here we made a recommendation against, because if you take in on average the effect of CNS stimulants, there were more harms than benefits. So there were more adverse events than benefit on average. So if you give it to the whole population, that doesn't mean that for an individual patient, might benefit from this. This is why it's a conditional recommendation. So in general, CNS stimulant is not a good idea for all the patients with PCC and cognitive symptoms and brain fog, but for some cases, especially with people who experience a larger improvement or experience fewer adverse events, may benefit from the intervention. So in selected cases, but not as a general. And the reason for that is because overall, there were more side effects than benefit. The next question, please. That was okay. So I will let you with Heather, who is going to introduce some, as I said before, we had more recommendation for you. We present a small sample of them. If you want to visit all the recommendation, you can access through our website and other resources. So please go ahead.
Sure. So I had the pleasure of being part of the Knowledge Mobilization Committee. And so I just want to talk to you a little bit about some of the resources that we have developed as part of this project. So the first one is the recommendation map, which is a free online tool that allows you to search for CAN-PCC recommendations. So you can search by topic and population, as well as the specific guideline team. We are currently working on developing a more mobile-friendly version of this because we recognize that a lot of people are accessing this on mobile devices. So this is something that's underway, and we hope to have finished within the next couple of weeks. Next slide. plain language recommendations. So this is a format that summarizes the recommendation and the key supporting information in a more user-friendly one-page view. So this is available in English and French for all of the recommendations. So we are also in the process of developing some resources for patients. And so I encourage you to check back here frequently over the next 2 weeks, because we are going to be uploading more resources as they are finalized by our Knowledge Mobilization Committee members. So the first one, go back, is the My Guide, which is you can access that at longcovidguide.ca. And this is a customizable online self-management tool that healthcare professionals can refer their patients, and patients can also access this to guide their own decision making. We also have interactive infographics and online resource sheets that are being developed and finalized as we speak. These will be offered in both French and English, and several of them will be offered in other languages as well. All the webinars will be posted on our resources page under events, and they'll be accessible in both official languages. We're also developing some resources for health professionals. So the University of Saskatchewan developed some CME accredited webinars that can be accessed through the website that you see listed on the slide here. There's also an online CPD course that will be a free bilingual 2-hour course covering diagnosis, referral, and management strategies. So that is currently underway as well. And then there's also an interesting program that was a training program for internationally trained health professionals, and it covers the basics of evidence-based medicine as well as post-COVID condition. And that website is also posted there. Okay, so if you have any questions, please feel free to share them in the Q&A section. We're going to address as many as we can, including those that were shared ahead of time and upon registration. Okay, Robbie, did you want to take the first question that's in the Q&A?
Let me have a look, and I think Ignacio can probably help answer this as well, and perhaps Kimberly. So the first question is from Nicole, right?
That's correct.
I'll just read it out so everybody is aware what the question is. The implication of screening for depression and anxiety in individuals with long COVID is that this is a mental health issue. It is dangerous to link mental illness with a physiological illness like long COVID, especially since you said depression is present in the general population. Is screening for depression so closely linked to cancer patients, for example? Ignacio or Kimberly, do you perhaps first want to answer? I can add as needed.
Kimberly, do you want to go first?
I'll put it in the chat as well, the question, perhaps.
There we
Is
go.
that okay?
I was just unmuting. Yeah.
Okay.
So I guess what can I say? Because I've lived both. So I think you know, living as a person with a cancer condition that has left me with lifelong debilitating symptoms, in addition to then acquiring long COVID. I think what we were trying to address in this is acknowledging a holistic approach. And it was not, I think, meant to dismiss long COVID symptoms. But certainly, I think we were very acutely aware of what I think in the patient community, what many of us have experienced, and I have experienced personally as well, is around the gaslighting, which really comes down to working with your healthcare team. I think the educational process that we're all going through and learning about this condition, and also having healthcare providers, understand no matter what condition it is, how really important it is to ensure that patients are heard first and foremost and acknowledged, no matter what the condition is that they're going in to have looked at. So I think that this certainly was a, how shall I put it? It was a tricky one to navigate because it comes with valid like sensitivities around it, and for very valid reasons. For the simple fact, I can speak from my personal experience. You know, it took a year for me to even be acknowledged, and this was working with a healthcare provider that I fully trust and have a long history with, because we were all navigating something that was very uncertain. And so, you know, is some of the gaslighting intentional? You know, it's always hard to say. But I think that this was probably one of the most sensitive topics that we worked on as a team, and some of the clear messaging that we're trying to certainly give through the project, and certainly from our team as well, is first and foremost to acknowledge that long COVID or post-COVID condition is real. That's a key message, that it is real, it is valid. And then moving forward, how do we better address that in the healthcare system? And as patients, how do we work as a team with our care providers in acknowledging that and then addressing that? But again, I think it comes back to the reason why this was such an important question and topic is really this, you know, we looked at it to ensure that there's a holistic approach being taken. So I hope that sort of helps. And certainly there was long and vigorous discussions around this particular question, and also around the anxiety question. Ignacio, maybe you have something more that you'd like to add?
Yeah, and in medicine, it's not unusual that some diseases are associated. So, for example, let's take another example. If you have diabetes, you have more chances to have hypertension. So you say, well, if you find someone with diabetes, you need to screen for hypertension, because those diseases tend to happen together, and they have different treatment. So what we're trying to do with this recommendation is to acknowledge that anxiety and depression are mental health issues separate from PCC, but they may happen together. And if you treat only the PCC symptoms and do not treat depression or anxiety, people might not get well enough. So that is what we're trying to say. So, well, not the original PCC symptoms are mental or relation with the mental health, but they may happen in association. And from the evidence we have, they tend to happen. There is a lot of times that happen in association. So it is important to be vigilant of this condition rather than dismiss everything. So, well, there is two scenarios. You say, well, these symptoms are because you have PCC, or these symptoms are because you have depression. So, well, they are different conditions. And because they are different conditions, they need to be distinguished. That is kind of the main message from our guideline.
Thank you, Ignacio and Kimberly. Great answers. I won't add anything to that. I also see there's a related question after that from Kari. It's quite long, so maybe, okay, can you see it, Ignacio and Kimberly? Can you see the question? I'll just mention perhaps the essence of the question, and then we can perhaps talk about that. I think we've addressed most of it already. So I think the essence here is treating the PCC or long COVID should be first and foremost. Once it has been formally diagnosed and acknowledged, then look at depression. So would that be an option, or yes, do you want to address that?
Yeah, I can go.
Sorry, go ahead, Kimberly, go ahead.
Okay, thanks, Ignacio. So Carrie, absolutely, right? I mean, I think those of us with lived experience, it is debilitating in itself. The fact that we were all facing a really unknown created additional challenges. You know, it's the frustration of working through that, and also a healthcare system that was learning really along with us. It's very evident that, you know, it can cause even more issues for us as we try to navigate it. I think it, if I can reflect back to just even my cancer experience, just in contrast, you know, a cancer experience also, there's a lot of work and supports around mental health now as well. But that, because it was cancer is a better understood collective of diseases, because we know it's not just one disease. So it is very multifaceted and very complex as well. The cancer that I previously had was a rare form of cancer as well. So I navigated something that was very unknown. So I've had to go through sort of those uncharted territories as well. But certainly what we've learned from even that, I guess, arena is the importance of really taking that holistic approach. And it took, even in the cancer experience, it took a lot of advocacy from patients and caregivers to actually even have the question of mental health and wellness being addressed during our appointments, where now it's actually part of the conversation. And that certainly took time to evolve and be adopted and refined in the care and treatment process. So I think that's, again, where the intention was here, is to ensure that that is not overlooked or set aside, because it could very well be a very important aspect on a personal level. But just working through the system as well can create so much frustration and mental distress. And I think it's really important that we all address that and acknowledge it. And I think Carrie, you really have said it perfectly, that it can, in some cases, be even a causal effect of addressing this, quite frankly, really unknown disease in a system that, you know, is, I think, is doing its very best to try to address it. And so projects like this have been so important to bring it to the forefront, and the advocacy that we all continue to do will help support that moving forward. And certainly that is my hope. And that's what we can, I guess, do or empower ourselves to do moving forward. So I'll hand it over to you, Ignacio, if you have anything additional.
Yeah, for example, there is a bunch of medical condition that, for example, if you have cognitive decline in the elderly, if you don't identify depression as a comorbid disease, so as a separate condition that needs treatment, that needs a specific diagnosis treatment, the symptom from cognitive function will not improve. And so I think the basic message is there's different conditions: anxiety, depression, and PCC. All of them require proper diagnosis and treatment. What we meant to do with this recommendation was to highlight precisely that. If you treat anxiety but don't treat other PCC condition, people might not get better, but it's the other way around as well. So we try to, this recommendation is actually a point to bring this discussion and all this concern forward to the providers, and to provide some guidance in that they need to be assessed separately. And I think the alternative was not to not say anything, which I think is far worse.
Okay, I'm just going to go on to another question that's in the chat. It says, could you kindly give more information about the other frequent neurological symptoms of PCC besides brain fog? So maybe you could indicate, Kimberly and Ignacio, what recommendations are also addressing other neurological symptoms?
Ignacio, is it okay if I let you take the lead on that?
Yes, not a problem. So there is it's difficult to know, right? Because when you say a symptom is neurological or of related to mental health, because they are kind of broad. But we focus our recommendation in mental health. So it's symptoms from mental health condition like anxiety and depression. But also there's an whole bunch of recommendations related with cognitive decline or cognitive inefficiencies. The problem we have now is we call cognitive decline or cognitive impairment, but this was developed for dementia, right? Where it's a progressive disease. So now we're dealing with that situation. We don't have a proper term. So we spend a lot of time how to call it. And at the end, I think is what we stick with cognitive impairment or cognitive symptoms, but we realize that that language was developed for another condition. So maybe we need a better term in the future. But there was a lot of people feeling tired, people feel not able to remember so things, or feeling that their performance was even slower without being able to point out what specifically was happening. So we are dealing with mild cognitive inefficiencies, at some point we consider, but those also, we have some recommendation for that as well. And there is one recommendation for smell loss. So what we have to do with neurologic symptom? Well, smelling is closely related to the brain. So we included in this group. You might think differently, should have been, but we have one recommendation about smell loss, and that's the most frequent symptoms of COVID, and is very prevalent as well in post-COVID conditions. So we have another recommendation about smell loss.
Okay, thanks very much, Ignacio. We're just going to wrap up. I see there is another question in the chat about healthcare systems and resources and ultra-specialized centers. We are having another webinar next week about healthcare services and systems. So I encourage you to join that one next week. Robbie, I'm not sure if you have a quick answer to that question.
Thanks, Heather. We're at time here, basically. So we will follow up on any questions that we were not able to answer here after the webinar. So I hope that's okay.
Sure. So as we wrap up today, we want to thank you very much for joining us. Don't forget to visit CAN-PCC.ca over the coming weeks. As I mentioned, there's going to be continued changes and updates and more recommendations released on March 31st. We have 2 webinars next week. The first one is on health systems on Monday, and pediatric recommendations will be on Thursday. I also encourage you to sign up for the newsletter so you'll continue to hear about other important releases coming up. And so we'd like your thoughts on today's session. So please take a moment to fill out our feedback survey. It will help us improve and continue to serve you. So have a wonderful day, and we'll see you next time.